Hello, students. Good evening, everyone. Am I audible? Am I audible, dear students? Shall we start? Give me a thumbs up. Okay. Should we start or wait for a minute so that more people can join in? Okay. Good evening, everyone. Hope I'm audible to you all. I hope all of you are doing great. With very few days left for your NEET PG, I'm sure all of you are in full gears. Full-fledgedly, you're focusing and maintaining the momentum. Let's begin this day one of NEET PG 2026, the final sprint pathology live sessions. We all know that the NEET PG pattern has been changed recently. I know it's a surprise for you all. Maybe it's a good surprise. Let's hope so. Pathology as such, we usually get 18 to 25 questions. Considering this pattern, there would be a few number of questions this time, 180 questions. So difficulty level would definitely be moderate. And I am sure there would be a large number of image-based questions. And obviously, there would be a large number of clinical case-based questions also. My opinion, there would be very few direct recall because this time the questions are expected to be longer in the same sense that the stem of the questions would be longer. But please don't worry. This is just a gimmick. Please don't worry. You just read the question properly. Give only one reading for the question, identify the buzzwords. You just know, pay importance to the buzzwords. I'm sure you must have read all the topics, all the high yield topics. The questions would be the same, but they would be packed in an exotic gift pack. That is it. Questions would remain the same, the subject would remain the same, the topic would remain the same. They would be just framing the questions to scare you, but otherwise, everything remains the same. Okay. Direct recalls, I know direct recalls would not be large in number, but then definitely all the high yield topics, all the previous year topics, the high yield topics would be there. Okay, so let's start. I have divided this session into 4 sessions in 3 days. Today we'll be discussing the general part. Tomorrow, 20th July, we'll be discussing part 1 hematology that would cover the RPCs and WBCs. Day 3 will be covering the second part of hematology, that is platelets, blood banking. Plus, we'll also cover the systemic pathology. Day 4 would be a test, followed by day 5, we'll be discussing all the questions. Please note, general pathology plays a very important component of your exam. Around 25 to 30% of the question would be there from general pathology. Your 18 to 25 questions, 25 to 30% would be general pathology, 40 to 50% from hemat. Systemic, you can say systemic around again 25 to 30% from systemic. So hemat, I have also included hemat in 2 sessions trying to cover everything because hemat forms the major component of your questions. All right. So I would say it again. Please don't be scared of the new pattern. All the questions packed in a different exotic gift pack. That is it. All right. So let's begin with the general pathology. I would begin with reversible and irreversible cell injury. What is cell injury? Cell injury forms the basis of your pathology, basically. Everything, the pathology starts from cell injury. So we have two types of cell injury, reversible and irreversible. Reversible injury, injury that can be reversed to normal. That is, the normal can be retained. It can be reverted back to normal once the stimulus is removed. If the injury progresses to cell death, that is, the stimulus is not removed, injury progresses to cell death, it is necrosis and apoptosis. We all know ATP decreased here, both ATP decreased, irreversible, it is markedly decreased. What is the major differentiating factor? Reversible cell injury, there would be marked swelling, hydropic change, vascular degeneration, and this swelling would lead to membrane damage in the irreversible cell injury. Cell injury swelling, cell swelling will be there in reversible, but the membrane damage will occur in irreversible. Second most important point, swelling and loss of cristae in reversible cell injury, whereas the hallmark of irreversible cell injury is presence of amorphous mitochondrial density. Nuclear changes, again, no nuclear changes in reversible. In irreversible, you have karyolysis, pycnosis, karyorexis. The membrane blebbing is present in reversible, but membrane remains intact, and the membrane ruptures in irreversible. So the most important question, the hallmark of irreversible cell injury is your amorphous density in the mitochondria. This is because of your calcium deposits, right? And irreversible, sorry, this is irreversible and reversible. The first change that you see in reversible cell injury is hydropic change. This is because of the swelling. And why does this swelling occurs? Can anybody tell me? Why does this swelling occurs? This swelling occurs because of the failure of sodium-potassium ATPase pump. Okay, this failure, this swelling occurs because of the sodium-potassium ATPase pump. All right. Next cell injury is necrosis. Necrosis. What is necrosis? Necrosis is basically pathological cell death caused by severe injury. And please note, it is always associated with inflammation. Always associated with inflammation, necrosis should come to your mind, right? Right? So there would be loss of membrane integrity, leakage of content, enzymatic digestion of the cell, and inflammation, very important, surrounding the tissue. Types of necrosis that we have studied is coagulative, liquefactive, caseous, fat, fibrinoid, and gangrene. Very quickly, coagulative necrosis. This is the most common type of necrosis that you see. Most common type of necrosis seen, usually seen in solid organs, and the cause is ischemia. Ischemia. Your tissue architecture remains preserved. Tissue architectures remain preserved. This is a wedge-shaped coagulative necrosis area. All right, tissue architecture remains preserved. Second is liquefactive necrosis. We all know, where does it occur? Anybody, where does it occur? It occurs in brain. All right, brain, and because of enzymatic digestion. This is liquefactive. Caseous necrosis, we all know caseous necrosis is cheesy white. Where do you see caseous necrosis? Yes, you see it in tuberculosis. Caseous necrosis is basically a combination of your coagulative plus liquefactive necrosis. Okay, then fat necrosis, you see chalky white deposit. Chalky white deposits you see. For example, where do you see fat necrosis? You can see it in breast. Because of trauma, you can see it in pancreas. Why? Pancreas, because of enzymatic digestion of the fat. So that is why you see fat necrosis in pancreas. Now, coming to fibrinoid necrosis. Fibrinoid necrosis, where do you see fibrinoid necrosis? Fibrinoid necrosis is usually seen in immune-mediated vascular injury. You see it in immune-mediated vascular injury. Where else do you see, what are the examples of the diseases you see in fibrinoid? Where do you see fibrinoid necrosis? You can see it in rheumatic heart disease, polyarteritis nodosa. You can also see malignant hypertension. What do you see here? You see pink fibrin deposit. Okay, faint fibrin deposit, right? So this was fibrinoid necrosis. Next, we know about gangrene. Dry gangrene, wet gangrene, gas gangrene. Where do you see dry gangrene? Dry gangrene is because of ischemia. And usually seen in vascular disorders like Berger's disease, Raynaud's phenomena. You basically see the part is the organ or the part, the limb is basically dark, black in color and with a sharp line of demarcation, right? Plus you have wet gangrene. Wet gangrene you see venous outflow obstruction. Okay, venous outflow obstruction. Following a strangulated hernia, intersection, diabetic foot, also you see wet gangrene. Gas gangrene is because of clostridial infection. Where else do you see gas gangrene? Clostridial infection. Where do you see gas gangrene? You see it in muscles, colon. What is the important thing that you observe in gas gangrene? The organ is crepien, right? You can feel the gas. Okay, so this was about gangrene. Now, we've studied about necrosis. Now we're coming to apoptosis. I hope I'm clear to all of you. Okay. So, apoptosis. What actually is apoptosis? Apoptosis is basically programmed cell death. What is apoptosis? It is your programmed cell death without inflammation. There is no inflammation here. Very important differentiating feature from your necrosis. There is no inflammation here and it is programmed cell death. We have two steps, as we all know, initiation and execution. Initiation में what caspases are involved? Your 8, 9, 10. And execution, it is 3, 6, 7, right? Intrinsic and extrinsic are again two pathways of initiation. Intrinsic is due to cellular stress and extrinsic is due to an outside, probably due to a ligand. Okay. And the caspases involved is caspase 9 in intrinsic and caspase 8 and 10 in extrinsic. All right. Now, okay. So how do we remember the caspases? Because you all know caspases are asked in questions, which caspase is involved in which pathway. See, we all know apart from 5, 3, 6, 7, 8, 9, 10. So 3 to 10 apart from 5 are involved in apoptosis. Initiation coming first. So the caspases that are in the end, 8, 9, 10. All right. Execution coming later, caspases coming in the beginning, 3, 6, 7. Again, intrinsic coming first, the last caspase. 8. Sorry, caspase 9. And extrinsic, just remember 8 and 10. The ones left, 8 and 10. All right. So initiation coming first, the last caspase is involved, 8, 9, 10. Execution coming later, the initial caspase is involved, 3, 6, 7. I hope you will be able to remember by this method. Okay. Next, the intrinsic pathway. See, intrinsic pathway is also known as mitochondrial pathway. I already told you the cellular stress plays a very important role in intrinsic pathway. 1 second. Okay, intrinsic pathway, again, initiation, execution. Initiation, two pathways, intrinsic and extrinsic. Okay, intrinsic pathway, also known as mitochondrial pathway, कौन सी caspases थी? If you remember, caspase 9. Okay, 8, 9, 10 in initiation and intrinsic, there is caspase 9. There is a cellular stress followed by BACs and BAC activation, which I'm going to tell you in a while what are BACs and BAC. These lead to mitochondrial outer membrane permeability. Mitochondrial outer membrane permeability. which then the cytochrome C and apoptotic factor 1 together forms apoptosomes. These apoptosomes now activate caspase 9. I told you intrinsic pathway, caspase 9. So it's a cellular stress that is the initiating factor in the intrinsic pathway. All right. Now, coming to extrinsic pathway के लिए you need an external stress. The T cells has fast ligands. The T cells have fast ligands. They join with fast on your the cells to be apoptosed, and they recruit the FAD which activate caspase 8 and 10. Right? Intrinsic में caspase 9 was activated. Extrinsic में caspase 8 and 10 are activated. Now initiation done. अब क्या होगा? There would be execution. Execution, I told you, execution is the second pathway, the later pathway. So the initial caspases would be involved. That is, your 3, 6, and 7 will be activated by your initiation caspases. That is 8, 9, 10. Seems to be a little confusing, but just remember, pehla pathway is your initiation pathway. So the later caspases would be involved. Execution is your later pathway. So initial caspases would be involved. So caspase 3, 6, 7 are activated now. Now what will they do? They will fragment the DNA. Question that can be asked here is, what sort of fragmentation occurs in the DNA in apoptosis? So it is a step ladder pattern. If this is your DNA fragment, the DNA would be fragmented in this manner. Like this is step ladder pattern. So the cells will shrink, membrane blebbing will occur, apoptotic body, this is the cell to be apoptosed, and apoptotic bodies will be formed, which would be phagocytized. Remember, phagocytosis will occur and there would be no inflammation. Okay, no inflammation. Now, coming to what are the factors that promote apoptosis, pro-apoptotic factors. What are the factors that oppose apoptosis? That are the anti-apoptotic factors. Okay, so pro-apoptotic factors are back and back. The anti-apoptotic factors are BCL2, BCLX, and MCL1. How will you remember? Please note, wherever you see BA, backs, back, these are pro. Wherever you see CL, these are anti. Okay, just try to remember. BA is pro, CL is anti. All right. Now, so very important differentiation between apoptosis and necrosis. Apoptosis is cell's own death, programmed own death. The cell programs its own death, whereas in necrosis, the cells are damaged by external factors. Apoptosis, the cell shrinks, the nucleus condenses, and the cells breaks into apoptotic body. If this is the cell to be apoptosed, the cells will break into apoptotic bodies and will be phagocytized. Whereas in necrosis, the cell swelling will occur, the plasma membrane will rupture, the contents are released into the external space, and it will trigger inflammation due to the release of cellular contents, whereas inflammation will not be there in the apoptosis. Then you can be asked questions. What are the examples of apoptosis and necrosis? Necrosis could be damage due to burns, ischemia, infection, and apoptosis usually is programmed. So whatever is not needed by the body is usually apoptosed, or the cell which has reached its senescence will be apoptosed. So it is removal of webbing between the fingers during development, or elimination of damaged cell by the immune system. So you can be asked questions about the examples of apoptosis and necrosis, and very important, you have to remember that necrosis is associated with inflammation and there is no inflammation in apoptosis. Okay, till now the examiner's favorite question was difference between apoptosis and necrosis. 2025, last year they asked about necroptosis, ferroptosis, and pyroptosis. And the question that they asked was, caspases play a crucial role in which of the following types of programmed cell death? So can anybody tell me caspases play a role in which type of programmed cell death? Apoptosis, we know. Apoptosis, one answer we know that caspases do play an important role. Where else do caspases play an important role? Any suggestions? Any answer? Okay, so pyroptosis also, caspases play an important role. Now, what is pyroptosis? See, pyroptosis again, a type of apoptosis where inflammation is involved. So it's basically an inflammatory programmed cell death. And the caspase involved is usually caspase 1. Okay, it is also inflammatory programmed cell death where caspase 1 is involved. Necroptosis, it resembles necrosis. It resembles necrosis, but it is genetically controlled. Genetically controlled, and it is caspase independent. Please note, it is caspase independent. Then ferroptosis, as the name suggests, it is iron dependent. Iron dependent, and there is toxic lipid peroxidation in this process. And no caspase is involved. Okay, no caspase is involved. So pyroptosis, going back to the question again, caspases play an important role in apoptosis and pyroptosis, right? Necroptosis, ferroptosis, no caspases involved. Okay, coming to the differentiating feature, inflammation is there in apoptosis, no. In necroptosis, pyroptosis, and ferroptosis, inflammation is there. What did I tell you? Necroptosis resembles necrosis, but there is inflammation. Caspases are involved in apoptosis as well as pyroptosis, not in necroptosis, not in ferroptosis. Membrane pores are formed in necroptosis because it resembles, yes, because it resembles necrosis, and it is also formed in pyroptosis, right? However, there is this lipid peroxidation in ferroptosis. There are no membrane pores formed, right? So this was about necrosis, apoptosis, and the various types of necrosis we see. Now, coming to the pigments. Okay, pigments, what sort of pigments we know? We have exogenous pigments and we have endogenous pigments. What are the exogenous pigments that we know about? The exogenous pigments that we know about are carbon, silica, tattoo ink, the tattoos that these days all the kids use, and the carotene. These are all examples of exogenous pigments. Endogenous pigments, there are many. First of all, very important, hemosiderin. What are the causes for hemosiderin? Very important, hemosiderosis, bruises, hemochromatosis. And how do they appear on the histology? Histopathology, they appear as golden yellow granules. And Persian blue is the stain. Persian blue is the stain for iron. Hemosiderin is an iron-bound pigment, so Persian blue is the stain for hemosiderin. Wherever you see iron, wherever you see hemosiderin, the special stain, that is Persian blue, right? Then the next is melanin. Melanin usually seen in chloasma and Addison's disease and melanomas, of course, brown granules. Fontana Mason stain is an important stain for special stain for melanin. Then we have also heard about wear and tear pigment or the lipofuscin. This is usually a pigment of aging, malnutrition, and cachexia. It's seen in golden brown color and perinuclear in location. And the stain used is Sudan black B, long loop Zeal-Nielsen, or pass positive stain, right? Bilirubin, of course, we see it in jaundice, cholestasis, seen as yellow-green pigment, and Pouchet stain. Okay, please note down, you have to remember the special stains, at least for the important ones: iron, Persian blue, melanin, Fontana Mason, and then we have homogentisic acid or the chromatic pigment and seen in ochronosis. It's seen as bluish brown, bluish black, dusky pigment, and the stain uses chromol stain. Okay, or silver based stain, Fontana Mason stain can also be used. Copper, we all know Wilson's disease, and the stain used is rhodamine stain or the Reuss stain. Calcium, you can see it in dystrophic or metastatic calcification, and the stain used for calcium is von Posa or alzarin red S stain. Then malarial pigment or the hematine neozoin pigment, you see it under polarized light, they are birefringent, and histopathology you see as dark brown to black pigment. So we are done with exogenous and endogenous pigments, right? Okay. Now coming to a question that was asked in your previous year, NEET PG 2021, a 65-year-old man presented with cough, easy fatigability, weight loss. Bronchoscopy revealed squamous cell carcinoma. Histopathological examination, resected hilar lymph node was 1 centimeter in measurement and contained black deposit. Which of the following pigment is the cause of this black discoloration? See, this is a perfect example of what sort of question I was talking to you in the initial initial portion of my session. That question is very simple. They just made the stem of the question longer to make you confused. Squamous cell carcinoma is the diagnosis, but lymph node shows black pigment. So even if squamous cell carcinoma is not there, a lymph node showing black pigment, what would be the answer? Yes, the answer would be anthropotic pigment. Simple, even if squamous cell carcinoma wouldn't have been there. Because of this pollution, because of the environment that we live in, anthropotic pigment, the carbon pigment, will be there in the hilar lymph node. All right. So moving to the next question that was also asked in previous exam. A young patient with paroxysmal nocturnal dyspnea had hemoptysis and died, and autopsy revealed hemosiderin-laden macrophages in the lung. So most probably this is a case of chronic heart failure. All these findings can occur in the following condition except, so hemosiderin-laden macrophages can be seen in pulmonary venous obstruction, right heart failure, volume overload, protein-losing enteropathy. Which all cases hemosiderin-laden macrophages will not be visible. So can anybody tell me the answer? Okay, hemosiderin-laden macrophages will not be seen in protein-losing enteropathy. Why? Because all the other cases are causes of chronic heart failure, right? So that is why hemosiderin-laden macrophages can be visible in the ABC options, but not in protein-losing enteropathy. All right. Now, coming to very important acute inflammation. We all have studied acute inflammation. There are vascular events and cellular events. Okay. How do we remember the vascular events? How do we remember the cellular events? Vascular events ke liye, what is the mnemonic that we use and how many vascular events that we know about? See, for vascular events, remember the mnemonic, very, very hot shot. Okay, very, very hot shot. So there are 4 vascular events, VVHS. Cellular events, there are 7 cellular events. And how do we remember? Mr. A.D. Koch. Okay, Mr. A.D. Koch. So vascular event 4, cellular events 7. Vascular events. The first vascular event is vasoconstriction. Remember, very, very hot shot. Okay, very, very hot shot. Vascular event, vasoconstriction. Vasoconstriction is the immediate, within second, whenever there is an injury, the first vascular event that is going to occur is vasoconstriction, immediate. within seconds. Okay, and it is a transient event. Transient event, a reflex event. Okay, transient event. So first is vasoconstriction, first week. Second is vasodilatation, second week. Vasodilatation is what? Vasodilatation, the blood will. What is vasodilatation? Where does vasodilatation occur? Vasodilatation will first occur in arterioles, then in capillaries, and then in venules. Okay, this would lead to increased blood flow. Basically, there's a site of injury, the blood flow first reflexes vasoconstriction. After that, there would be increase in the blood flow to that injured blood vessel, and increased blood flow will lead to Weber and Kaller. I hope all of you remember the cardinal signs of inflammation. Weber is redness, and this is heat or increased temperature. So vasoconstriction, vasodilatation. Third is very, very hot. Hyperpermeability. Okay, hyperpermeability. So what will occur in hyperpermeability? There would be endothelial contraction. See, if this is an injured site, the endothelial cells will contract. Endothelial cells will contract and there would be exudation of fluid. There would be exudation of fluid, right? Which will result in fluid extracellularly causing swelling. That is your next cardinal sign, tumor. Okay, so we have a cardinal sign, Ruber, Kaller, tumor, Daller. So this is tumor. So because of loss of fluid, what will occur? The blood will become viscous. The blood will become viscous. And because of viscous, there would be stasis. Stasis. So your fourth vascular event. Remember, very, very hot shot. Vasoconstriction, vasodilatation, hyperpermeability, and S for stasis. All right. So these were our vascular events. Now, coming to the cellular events. Cellular events, ke liye what mnemonic did I tell you? It was Mr. A.D. Koch. Okay, Mr. A.D. Koch. So Mr. Ka M is your margination. What occurs in margination? The WBCs will move towards the vessel wall. The WBCs will move towards the vessel wall. This is margination. And how do they move? They roll around. That is R, Mr. Margination, rolling. They roll around. And what are the factors responsible for rolling? These are your selectins, P, E, and L. Okay, your selectins P, E, and L will be responsible for rolling. Okay, Mr. Over, now AD. Now they have rolled towards the blood vessel. What will occur? Adhesion of the leukocytes on the vessel wall. Now, how do they adhere? Because of the, Now, how do they occur? Because of the integrins on the leukocytes and the cell adhesion molecule on the vessel wall. Right? On the vessel wall, on the endothelium. On the endothelium. So, this is adhesion occurred. Now, these leukocytes want to come out. Why do they want to come out? Because they want to go to the site of injury, site of the target cells or the microbes or any infection that has occurred. So, coming out of the vessel wall is diapedesis or transmigration. So, Mr. Margination, rolling, AD, adhesion or diapedesis. And this is mediated by your PCAM1. PCAM1 is CD31. Okay? PCAM1 is, PCAM1 is your CD31, right? All right. Mr. Over, AD over, now coming to COP. What do you mean by COP? COP. What is the actual role of a neutrophil as a COP? What does a COP do? Catch the thieves. What is the thief here? The injurious agent is the thief here. Okay. The injurious agent is the thief here. The COP or the neutrophil has to go out. Diapedesis occur. It has to do chemotaxis. Now, what is chemotaxis? Basically, movement towards the chemical signals. And what are the chemoattractants we know about? C5a, IL-8, and leukotriene B4. These are the chemoattractants we know about, and the neutrophils will go because of this chemoattractants. Then, what do after chemotaxis? What is it? Opsonization. What is opsonization? It is basically recognition and attachment to the injurious agent. What are the opsonins that we know about? These are IgG and C3b. Okay. Finally, the COP has attached to the injurious agent. What will occur? There will be phagocytosis. Phagocytosis and eventually killing and degradation of the injurious agent. All right. So very quickly again, vascular events are Mr. AD COP. Margination. The neutrophils will go towards the margin of or towards the vessel wall. Then how do they go? Rolling, mediated by selectins. Next, adhesion because of integrins present on the leukocytes and cellular adhesion molecules on the endothelium. They will adhere to the vessel wall and they will move out of the vessel wall because they will move out of the vessel by the PCAM. After that, chemotaxis, C5a, IL-8, leukotriene B4, they will recognize and attach to the injurious agent. The opsonins that we know about are IgG, C3b, eventually result in killing and degradation of the injurious agent. This was about very brief in vascular and cellular events of acute inflammation. Okay, so a question indirectly that talks about COPD but is actually related to acute inflammation. A patient with COPD develops symptoms of adult respiratory distress syndrome. Which of the following best describes the role of IL-8? Now, where did we study about IL-8? IL-8 was basically a chemoattractant. Okay, chemoattractant. And what does this chemoattractant do? It recruits more neutrophil, right? It recruits more neutrophil so that their action can be enhanced, right? Understood? Okay. Now, mediators of inflammation that we know about are cell-derived mediators and the plasma-derived mediators. The most important are histamine and serotonin, which are responsible for vasodilatation. Then we have arachidonic acid metabolites. Then we have platelet activating factors, cytokine, nitric oxide, and reactive oxygen species. Then the plasma-derived mediators, remember all the systems, kinin, clotting, complement, and fibrinolytic system. These are all the mediators of inflammation. Okay, now moving on to the types of giant cells that we know about, right? What are giant cells? They are basically, the basis of giant cells are, what are the cells of origin for giant cells? These are macrophages. Yes, they are macrophages. And what are the types of giant cells that we know about? The most important, most commonly talked about is Langerhans giant cells. So these are basically macrophages or epithelioid cells. Well, how do they look like? They have horseshoe shape with a peripheral ring-like arrangement of the nucleus. Okay, horseshoe shaped, the peripheral nuclear arrangement. Okay, so these are Langerhans giant cells. Where do you see Langerhans giant cells? Very commonly seen in tuberculosis. Then foreign body giant cells, again macrophages, they're disorganized, scattered nuclei. And where do you see? You see it in foreign body, like suture, talc, or even in breast implants. These foreign body giant cells can be seen. Then the next is Teuton giant cells. Again, macrophages. They are foamy, lipid-rich with a peripheral cytoplasm. Ring of nuclei. There's a ring of nuclei with a foamy, lipid-rich peripheral cytoplasm. Where do you see them? You see it in xanthomas. Okay, xanthomas. Then Ashkoff giant cells, what are these? These are cardiac histiocytes, we all know. And they are multinucleated, could be unilocular also. And where do you see them? You see it in rheumatic heart disease. Then Warthin Pinckedley cells, hyperplastic lymphocytes, where do you see? They have very large number of nuclei. More than 100 nuclei can be seen, grape-like cluster. Where do you see? You see it in measles. Yes, you see it in measles. Okay. Then sand giant cells, they are squamous keratinocyte, multinucleated, 3M, molding, margination, and can anybody tell me? Molding, margination, and where do you see them? You see it in multinucleate, molding, margination. Okay. The 3 M's of sand giant cells are multinucleation, molding, and margination. You see it in herpes simplex virus or even in varicella zoster virus infection. Reed-Sternberg cell, I'm not going to tell you. Everybody knows Reed-Sternberg cell, owl-eye appearance. Where do you see? Hodgkin's disease. Then osteoclast-like giant cell, they're again macrophages, multinucleated, dozens of nuclei, and you will see it in giant cell tumor of the bone. Okay, osteoclastoma, giant cell tumor of the bone. So this was about giant cell. The next, okay. So here's a question. A patient exhibits cough, stridor, dyspnea, lymphadenopathy. Lymph node shows granuloma with giant cells and stellate concretions. What is the most likely diagnosis? Now here we are talking about stellate concretions with a granuloma. Okay. Stellate concretions with a granuloma. What is it? Can anybody tell me? It is a sarcoidosis. Yes, it is sarcoidosis. Okay. Now, sarcoidosis, what do you see? You see bilateral hilar lymphadenopathy, elevated serum angiotensin converting enzyme. You see hypercalcemia and characteristic differentiating factor from tuberculosis. You see non-caseating granulomas here. Okay. There are non-caseating granulomas. And what do you see? You see asteroid bodies and you see Schaumann body. What is an asteroid body? Can anybody tell me what's an asteroid body? See, if you see this, asteroid bodies are basically stellate. Asteroid bodies are basically stellate or star-shaped concretions. There are stellate or star-shaped. Okay, star-shaped concretions made of compressed cytoskeletal elements. What are the cytoskeletal elements in asteroid bodies? They are your microtubules and filaments. Okay, microtubules and filaments. So these are asteroid bodies. On the other hand, what else do you see? You see Schaumann bodies. Schaumann bodies are what are Schaumann bodies? If you see here, Schaumann bodies are basically concentric lamellated calcified material. Okay, these are calcified material made up of calcium and iron. These are Schaumann bodies, and these two bodies are characteristically seen in sarcoidosis. All right, and the most important, it is non-caseating granulomas. You will see multinucleate giant cell, epithelioid cell, but the granuloma would be non-caseating. So this is sarcoidosis. Okay. Moving next to pedigree analysis. Please note pedigree analysis is very important from exam point of view. You will definitely get 1 or 2 questions from pedigree analysis. You will have to identify the autosomal recessive, autosomal dominant, or even the X-linked recessive diseases. Very important pedigree analysis. First of all, you have to note these symbols used. This is male, female, sex unspecified. This is proband. The arrow, proband. What does it mean? Proband means basically the first person. The first person that is to be identified, first person in a family that is identified with a genetic condition. The patient is also known as this person is also known as patient zero. Okay, proband is also known as patient zero. This is male and female affected, male and female carrier. This carrier is X-linked with a dot. This is autosomal. Okay, deceased, divorced, consanguineous mating, couple, offsprings. This would be the couple and this would be the offspring. This with dotted bracket is adopted in, line bracket adopted out, monozygous twin, dizygotic twin, zygosity unknown. All right, understood? Please note, you have to remember all these symbols. Now, first question, which of the following statement is correct regarding Mendelian inheritance? Can anybody tell me? Mendelian inheritance. Which statement is correct? Out of every five patients have an X, one out of every five patients have an X-linked recessive disorder? No, this is not correct. One out of every 10 patients are affected by Y-linked disorder? No, this is very rare. 2/3 of Mendelian disorders are autosomal dominant? Yes, this is the correct statement. 2/3 of Mendelian disorders are autosomal dominant. And 1/3 of Mendelian disorders follow autosomal recessive pattern, again incorrect. So, about Mendelian inheritance, 2/3 of the Mendelian disorders are autosomal dominant. Right. Now, let's study about autosomal dominant disease. There is always a vertical transmission. That is, the disease typically occurs in every generation. When you see a pedigree chart, the disease occurs in every generation without skipping. There is equal gender distribution. Transmission risk, 50% chance. What do you mean by incomplete penetrance? An individual inherits the mutant gene, but do not express it the clinical phenotype. That is what sometimes you do not see in one generation, but the patient does inherit the mutant gene, but does not express the clinical phenotype. But they do pass it on to their children. This is incomplete penetrance. Now, how do you remember the autosomal dominant disorders? They usually ask you in question that so-and-so disorder is what inheritance? Remember, autosomal dominant disorders dominate the family. That is 50% chance one parent can pass the disease. How do you remember? My very dominant father had many successful adventures. My very dominant father had many successful adventures. Marfan's, B is von Willebrand disease, dystrophia myotonia, familial hypercholesterolemia, Huntington disease, multiple endocrine neoplasia, hereditary spherocytosis, achondroplasia. All these are autosomal dominant disorders. Okay, then autosomal recessive disorders. This usually occurs in siblings rather than across the generation. It can occur in siblings. There would be skips in generations, right? You see in this pedigree chart, this generation has skipped, but siblings occur, the disease occur here. Again, equal gender transmission. But what is the transmission risk? When two carrier patients conceive, 25% chance affected, 50% chance asymptomatic, 25% completely healthy non-carrier individual. I hope I do not need to explain this. Very simple. There is a 25% chance no disease will be transmitted, 25% chance disease affected, the offspring would be affected, and 50% chance asymptomatic carrier. Okay, and okay, how will we remember the autosomal recessive disorders? See, recessive, as I already told you, both the parents are carrier, so recessive requires two parents. So please check every fan for grease. See, this is a mnemonic that I have created. You might be having different mnemonics, well and good, as far as you remember the diseases. Okay, please check every fan for grease. Phenylketonuria, cystic fibrosis, various enzyme deficiencies, your inborn errors of metabolism, Fanconi anemia, Friedreich ataxia, glycogen storage disorders. These are the autosomal recessive disorders. Okay. Now coming to the X-linked dominant disorder. X-linked dominant. The mutated gene is an X chromosome and it is dominant. So there would be no male to male transmission. Okay. No male to male transmission. Affected father cannot pass to his sons. No male to male. 100% affected father will pass his all the mutant X chromosomes to 100% of his daughters because only the X chromosome is being passed. Maternal transmission, again, a heterozygous mother has 50% chance of passing the disease to any of her children, be it male or female. Then we have something called male lethality. What is male lethality? See, males have single X chromosome, okay, single X chromosome, and many of the, because the single X chromosome cannot be compatible, so many of the X-linked dominant diseases would be lethal in utero. Lethal in utero, okay, leading to spontaneous miscarriages, right? Because a single X chromosome, it will be incompatible with life, it will be dominant, the X-linked dominant disease, because it will be incompatible in life. So male fetus, they would be lethal in utero. All right. So this was X-linked dominant disease, and very rarely it occurs because it is lethal in utero only. So very rarely father gets random disease. Vitamin D resistant rickets, Rett syndrome, fragile X, Gord's disease, and RD के लिए I've just put random diseases. Okay. So any, as I already told you, any mnemonic you learn about till the time you know what all diseases have, which all inheritance patterns. All right. Now coming to X-linked recessive disease. X-linked recessive disease, as the name suggests, there would be no male-to-male transmission. Why? Because father will pass only his Y chromosome to the son, not his X chromosome. Okay, X chromosome will be passed to the daughters only. Therefore, an affected father can never pass an X-linked disease to the son. The disease is usually seen in males. All right. Could be the disease is transmitted from an affected grandfather to his asymptomatic carrier daughters, who then produce the affected grandsons. All right. So this is known as oblique crisscross transmission. Okay. Now, moving next, how do you learn the X-linked recessive disease? Females will always give her boys X-linked disorders, but the males will not give. Females will always give her boys her X-linked disorders. Fabry's disease, Wiskott-Aldrich syndrome, ocular albinism, G6PD deficiency, the hemophilias, Bruton's A gamma globulinemia, Hunter's disease, then X-linked, severe combined immunodeficiency, or Duchenne and Becker muscular dystrophy. All right. Now, can anybody tell me this pedigree chart? You see female carriers. Okay, female carriers, only males are affected. This means it's an X-linked recessive disorder. Okay, This dot, if you see this dot, this means X-linked recessive disorder. So out of the options given below, options given alongside, which is it? X-linked recessive disorder? Yes, it is Wiskott-Aldrich syndrome. All right, Wiskott-Aldrich syndrome. So, next question. A couple seeks prenatal genetic counseling due to family history of hemophilia. I've discussed this question here because this talks about the inheritance rather than the hemophilia. Okay, so they already have one son with hemophilia and one healthy daughter. One son is affected, the daughter is healthy. We don't know whether the daughter is carrier or not, but the daughter is healthy. The mother's family is affected and the father's family is normal. What is the probability of their future children being affected? Okay, now we know hemophilia is an X-linked recessive disorder. Okay, hemophilia is an X-linked recessive disorder. So, 50% of the male children will be affected, 50% of the female children will be the carrier. Okay, both male and female children, all female male and children will not be affected, all male children will be affected, all female children will be normal. This is also wrong. All male children will be affected, half of the female children will be carriers. Again, this is wrong. 50% of the male children will be affected, 50% of the female children will be the carriers. This is what X-linked recessive disorders. All right. Now, coming on to the next, we have something also called Lyon hypothesis or lionization or X chromosome inactivation. Now, what is this actually? All the daughters, see, a female has what pattern 46XX. Blastocyst stage mein, there would be random inactivation of X chromosome. That is this inactive X chromosome will form your Barr body, right? So all the daughters will inherit the same inactive X chromosome. Okay, all the daughters will inherit the same inactive X chromosome, and this will result in mosaicism. Right? Only one X chromosome remains active. X chromosome inactivation, and this occurs in the blastocyst stage. Now, if we know the Barr body, how do we calculate the Barr bodies? Simple formula, number of Barr bodies is equal to X chromosome minus 1. If we have 46XY pattern, how many Barr bodies will be seen? You have one X chromosome, so you will have 0 Barr body here. Here you will have 1 Barr body. Again, 46XO Turner syndrome, you have 0 Barr body. 1 Barr body, and here we will have 2 Barr bodies. So you can also be asked about how to calculate the number of Barr bodies in various chromosome patterns. All right. Now, moving on to the chromosomal number anomalies. What are these called? Chromosomal, these are called aneuploidies. Okay, aneuploidies. What is the mnemonics that I have learned about? 3 toddlers on the pedal turned extra mysterious. So we have 3 trisomies turned extra mysterious. What are the trisomies that we know about? Trisomy 13, 18, 21. Go from smaller number to bigger number. 13, 18, 21. Pedal, fed, petau, Edward, down. Trisomy 21 down. I hope all of you will remember. Right? Trisomy 21 down. 18 is Edward. 13 is petau. Turned is Turner syndrome. We all know 45X. So, extra X chromosome, we have 46XXY and 46XYY. That is your Klinefelter syndrome. Or mysterious is mixed. So, for the chromosomal aneuploidies, remember 3 trisomies, 3 toddlers on the pedal. 13, 18, 21. Petau, Edward, down. Turned is Turner. Klinefelters, mixed. Okay? Chromosomal aneuploidies, right? Now, The DNA repair mismatch genes. What are the DNA repair mismatch genes that we know about? The diseases associated with DNA repair mismatch genes. Remember, FAB-N. FAB-N. The fabulous DNA repair gone wrong. Just remember FAB-N. Fabulous DNA repair gone wrong. So we know about Fanconi anemia. Okay, Fanconi anemia, ataxia, telangiectasia. We have Bloom syndrome. We have Nijmegen breakage syndrome. Okay, these are the diseases associated with DNA mismatch repair gene mutations. FAB-N. Anybody can tell me the mnemonics that they have learned about it? Okay, right. All right. Can anybody tell me the pedigree chart? What does this show? This shows two siblings. Two siblings. This couple got married. This couple got married. Should be this. No disease. All the children are affected because of the mother. All the children are affected because of the mother. So this is maternal inheritance, and maternal inheritance is usually due to mitochondrial inheritance. Which disease out of these shows mitochondrial inheritance? Prader-Willi-Williams syndrome or achondroplasia or Kearns-Sayre syndrome? Yes, the answer is Kearns-Sayre syndrome, right? So this shows mitochondrial inheritance. All the mitochondrial inheritance are inherited by mothers only. So the mnemonic also says, my mother loves keeping memories. My mother loves keeping memories. M is mitochondrial encephalopathy, lactic acidosis, basically the Mela's syndrome. Then second M is myoclonic epilepsy with ragged red fibers, MERRF, that's what it's all about. Then we have L, loves, Leber's hereditary optic neuropathy. K is Kearns-Sayre syndrome, the answer in the last question. And M is maternally inherited diabetes and deafness. All right. So this is diseases with mitochondrial inheritance. Now, we also have diseases with trinucleotide repeats. What are these diseases? These are Huntington's chorea, cerebral ataxia, Fragile X, myotonic dystrophy, dentorubral pallidolin atrophy, spinal and bulbar muscular atrophy, then again Friedreich's ataxia and epilepsy. How do we remember? High class fragile men don't show pride emotions. I could not think of anything else, but please, if you have any other mnemonics, please do let me know. Associated with trinucleotide repeats. Okay, now they've shown you this figure. Which of the following diseases associated with this chromosomal abnormality? This P is for paternal chromosome, maternal chromosome. Okay, if I tell you this is chromosome number 15, now the answer becomes simple. What is it? It is Prader-Willi syndrome. Okay, Prader-Willi syndrome. Remember, Prader-Willi P, paternal, Angelman, man, maternal. Although there is man here, but it is maternal. MMPP, right? So, if there is a mutated part of chromosome 15 from paternal, it is Prader-Willi syndrome. From maternal, it is Angelman syndrome, right? Okay. Now, coming to the various procedures that we do for all these, for detection of all these chromosomal anomalies or for genetic disorders. First of all, what is karyotyping? See, karyotyping is basically a process of arranging and analyzing chromosomes in cells, chromosomes in a cell. You arrange the chromosomes in a cell according to the number, size, the position of the centromere, and the banding pattern to detect the chromosomal abnormalities. Okay, so if you have around whatever number of chromosomes there are present in the cell, they're arranged separately, arranged in the order of the number, size, centromere position, and banding pattern. Okay, what is the sample that you take? You usually take the peripheral blood. Peripheral blood may be usually take the T lymphocytes, or we can also take amniotic fluid, or we can also take a bone marrow aspirate. These are the samples that you can take for karyotyping. Now, cell culture, what substance do you use in cell culture? You use phytohemagglutinin A. Phytohemagglutinin, that basically is a mitogen. Okay, it causes the cells to divide. And then there is a mitotic arrest. Mitotic arrest after 48 to 72 hours. And this is usually done by polychinine. Okay, and the arrest occurs at metaphase. The arrest occurs at metaphase. The arrest occurs at metaphase, and then we have to bring the cell to a hypotonic shock. We do it with the help of 0.075 mol potassium chloride. Why do we have to bring the cells to a hypotonic shock? So that the cells swell up, and the chromosomes present in the nucleus, they separate out and they do not overlap. So you can see the chromosomes later very nicely. Okay, no overlap, all properly separated. Fixation ke liye, what do you use? You use a Carnoy's fixative. Okay, you use a Carnoy's fixative. Then you have to do a banding and staining. What do you do? Basically, the suspension is dropped on the glass slide and it is stained, and you see distinct light and dark staining. Okay, light and dark staining. Then you use for microscopic analysis. All the chromosomes are now photographed. They are digitally arranged. And this pattern, this portion is called ideogram. Remember this pattern that you see is called an ideogram. Okay. Now, Denver classification of chromosome. How many groups of divided? Denver divided into 7 groups. A to G. Okay. Denver divided all the chromosome basically into 7 groups, A to G. And how do the chromosomes divided? Metacentric, submetacentric, and acrocentric. What is the category, or what is the criteria? The centriole. Basically, centriole is at the center. You have two equal arms of the chromosome, a little towards the unequal division of the arms. We have short arm, we have long arm. Short arm is at P, long arm is Q, or we have eccentrically placed centriole. That is, one arm is very short. This is very short arm. This is acrocentric placement of the centriole. So acrocentric chromosome, submetacentric and metacentric. This is normal, submetacentric and acrocentric. And what are the banding techniques we know about? We know about G banding, Q banding, R banding, and C banding. G banding, as the name suggests, G, Giemsa stain. Q banding, quinacrine fluorescent stain. R, reverse Giemsa stain. C banding, constitutive heterochromatin demonstration. All right. So this was about the types of chromosomes. Now, karyotype done. Now we are studying the fluorescent in situ hybridization or FISH. This is also a molecular cytogenetic technique that uses fluorescent label. Sorry. So this is fluorescent in situ hybridization, basically a molecular cytogenetic technique that uses fluorescently labeled DNA probe, okay, to detect the specific DNA sequence. Karyotyping means we were detecting the whole of the chromosomes. Here, we detect specific DNA sequences. So it is used to identify chromosomal abnormalities, gene amplifications, deletions, and translocation. Okay. The specific DNA sequences, of you we know about specific translocations. What do we do? The sample same blood, bone marrow, amniotic fluid. Here, even a biopsy sample can be taken. You denature the DNA, make it single-stranded. Okay, make it single-stranded. Why? Because we have to fluorescently label the DNA. Now add fluorescent DNA probe hybridization of the probe to the complementary DNA. Whatever DNA we have denatured and make it single-stranded, complementary to it, we add the fluorescent fluorescently DNA probe hybridization. Then we wash off the unbound probe and visualize it under the fluorescent microscope using fluorescent signals, right? Now, this was fish. Now coming to PCR. PCR is what? It is a technique used to amplify. Karyotyping was whole chromosome. Fish was particular portion of a gene. PCR is basically you amplify a single copy of DNA, specific segment of DNA across several orders. So you get thousands to millions of copies of that particular DNA sequence. And please note, it is done in vitro. It is done in vitro. First, you denature it, anneal it, extension, and there is exponential amplification. If they ask you what is the exponential, 2 raised to the power n, whereas the n is the number of chromosome, number of specific segment of DNA that you have used. Okay. So what do we do here? You take a template DNA that needs to be amplified, denature it at a high temperature, single-stranded DNA is isolated, annealing is done so that the primer can bind to it. Once the primer bind to it, there is extension. Again at 72 degrees Celsius, DNA synthesis occurs using top polymerase. When this cycle is repeated 25 to 40 times, you get millions of DNA copies. Okay, take the template DNA and you repeat it 25 to 40 cycle, you get millions of DNA copies. Now, what all type of PCR we know about? Conventional PCR. What is the conventional PCR? Basically, it detects the presence or absence of DNA. Real-time PCR. Remember, real-time PCR is qPCR. That is quantitative estimation of the result. Reverse transcriptase is RT-PCR. What do you do here? You detect the RNA viruses here. Okay, RNA viruses here so that how do we detect RNA viruses? By converting it into detection of RNA viruses by converting the RNA into DNA. Multiplex RNA, you amplify multiple targets. Amplify multiple targets simultaneously. Then nested PCR is somewhat related to increase in sensitivity and specificity. All right. So these are the various types of PCR that we know about. Now, very quickly differentiating the PCR, FISH and karyotyping. Gene mutation के लिए the best test is your PCR for gene mutation. Okay, but for micro deletion or for chromosomal translocation, FISH is the best test. PCR also detects chromosomal translocation, but the best test is FISH. Now detects the whole chromosomal abnormality that we have spoken about is karyotyping. Dividing cells are required in karyotyping. Again, PCR fish, we don't need dividing cells, we just need the DNA. Speed, this is the slowest, PCR is the fastest, and fish intermediate. Fish is also fast. Okay, but PCR is fastest. Now, if you are asked about which test is the best, karyotyping, fish, or PCR? See, as such, you cannot tell which test is the best. It basically depends on various circumstances, the requirement that you have. For a karyotype, why do you need to do a karyotype? If you want to look at the entire chromosomes or all chromosomes. For example, in aneuploidy, any cases of aneuploidy, you would like to do a karyotype first. That would be the best test. Fish, where all we need to do fish? To find a specific chromosomal defect. Okay, supposing a translocation or a microdeletion, or for example, in cases of CMF, where you know translocation 922. What is this called? Philadelphia chromosome. A specific chromosome defect, if you need to know about, the best test would be fish. However, if you want to pinpoint a specific gene defect, you would like to do a PCR. Supposing here CML only, BCR-ABL gene, if you have to demonstrate, BCR-ABL gene mutation, if you have to demonstrate, you will do a PCR. Even for all the other point mutations. Okay, you will do a PCR. So basically the requirement, if you want to see the entire chromosome, you have to do a karyotype. If you want to find a specific chromosomal defect, you do a fish. Or if you have to demonstrate a specific gene defect, you do a PCR, right? Okay. Now, this is a karyotype that I was talking about. All the chromosomes are separated out, no overlap. You can identify all the chromosomes. So you have a short girl, primary amenorrhea, who has not obtained puberty. What is the chromosomal defect? If you see the karyotype here, chromosome occur in pairs. You see occurs in pairs. But the X-sex chromosome, you have only one chromosome. You don't have the other chromosome. Neither it is a female 2X nor XY. Basically, you don't have the second sex chromosome. So that is 46XO. Okay, 46XO. What is this? Turner syndrome. And as the clinical features also suggest, short girl, primary amenorrhea, not attained puberty. It is a Turner syndrome. So such cases where you want to see the entire chromosomal analysis, the best test is your karyotype. Okay, karyotype would be the best test. All right, now coming to very important molecular basis of neoplasia. Molecular basis of neoplasia, I'm not going into detail because I'm sure you must have already read about what is the molecular basis of neoplasia. Just very quickly revising, how do cells move towards neoplasia? First, growth and unchecked growth and proliferation. Unchecked growth and proliferation, how does this occur? On proto-oncogene mutation. What is proto-oncogene mutation? Basically, your oncogene mutations. Okay, the oncogenes. Anti-oncogene or tumor suppressor gene mutation. What do you anti-oncogenes or tumor suppressor genes do? Basically, they act as brakes. So there is a removal of this brake for cell growth. When there is removal of this brake, the cells will keep on dividing. Okay, so there is growth and proliferation, first factor. Second is favorable overall cell survival. Favorable overall survival. Avoiding DNA repair. Once the DNA mismatch occurs, there is no repair. The genes get mutated. Cells escape death by apoptosis. Remember I told you, apoptosis, all the damaged cell, all the cells that are not required by the body, they apoptose. So If the cell's apoptosis is escaped, that is, what are the genes involved? The genes involved, we have already studied about that. The anti-apoptotic and the pro-apoptotic. Remember the bad BCL, the bad genes and the CL genes, okay? Anti-apoptotic and pro-apoptotic. Then avoiding cell senescence. How do the senescent cells don't die? So that is overall survival. What is responsible for cell senescence? Telomerase. Telomerase enzyme, okay? Then autophagy. Okay. Then another basis of neoplasia is vascularization. Vascularization, angiogenesis, proliferation of cells, metastasis, and then growth promoting and metabolic changes. Warburg factors, Warburg effect. We are going to study it in a while. Warburg effect. Then there is dynamic tumor microenvironment, or could be immune modulation leading to cell survival and cell proliferation. So this is the basic of your molecular basis of neoplasia, basic of neoplasia. Now, I was talking about telomerase, cell senescence. These two questions were asked previously. What statement correctly reflects the telomerase theory of aging? Now, we all know telomerase was the portion of, what was telomerase? If I tell you, if we come to this slide, this portion, the topmost portion of a chromosome is known as a telomere. Okay, this keeps on dividing and the cell, this keeps on dividing, shortening, basically not dividing, this keeps on shortening, and which helps in cell senescence. Okay, so coming back to the question again. Okay, which statement correctly reflects the telomerase theory of aging? Aging is linked to shortening of telomere? Yes. Aging is linked to increased telomere length? No. Aging is linked to telomerase stability? No. Aging is linked to abnormal telomerase activation? No. Aging is linked to shortening of telomere length. Because of the shortening of telomere length only, the senescence occur. All right. So this is the correct answer. Also, because a similar type of question was asked, which of the following measure is associated with an increased lifespan? Okay, increased lifespan is associated with decreasing stress, pharmacological intervention with proton pump inhibitors, moderate regular exercise, decreasing caloric intake by 30%. Although all of them appear to be associated with increased lifespan, except for this, but the most appropriate answer in this case would be decreasing caloric intake by 30%. If you decrease your caloric intake by 30%, there is an association of increased lifespan. Okay? Right. Now, very quickly revising the oncogenes, proto-oncogenes, anti-oncogenes that we studied in the molecular basis of neoplasia. Proto-oncogenes, as the name suggests, they promote normal cell growth and division. What are the examples? The growth factors are platelet-derived growth factors, transforming growth factors, fibroblastic growth factors, hepatocyte growth factors. All the growth factors are proto-oncogene. They promote cell growth. Then certain growth factor receptors also we have. Cytoplasmic signal transduction proteins, nuclear transcriptor protein, cell cycle proteins. Okay, you can be given as a question that platelet-derived growth factors, TGF, alpha, FGF are all examples of, they are all examples of proto-oncogenes. What do anti-oncogenes or tumor suppressor genes do? I already told you they act as brakes for cell growth. So they safeguard, they basically regulate the cell growth. So what are the examples? RB gene, P53, TGF beta, APC, beta catenin, BRCA1, all your Other examples are anti-oncogenes. Then anti-apoptotic. They prevent apoptosis and in fact promote cell survival. We've already studied this. All the CL genes, MCL, BCL, BCL-XL are anti-apoptotic. On the other hand, pro-apoptotic are promoting apoptosis, your bats, back and bat. All right, these are pro-apoptotic genes. Now, coming to the P53 or the guardian of genome. P53 is also known as guardian of genomes. The chromosome responsible for a chromosome where P53 is present, it is 17p13.1. The CDK inhibitor, all these are straightforward questions. Chromosome of TP53 is 17p13.1. The CDK inhibitor induced by P53 is P21. The negative regulator is MDM2. This is basically a NEET3 ubiquitin ligase. Checkpoint controlled by P53. Where does it act? It acts at the G1S phase of the mitotic cycle. And the most common tumor suppressor gene mutated in cancers is basically your TP53 only. And syndromes, can anybody tell me what are the syndromes associated with TP? Syndromes due to the TP53 mutation association? It is your Lie-Promani syndrome. Okay, straightforward questions for P53, also known as guardian of genome. Now, how does this P53 act? Whenever there is DNA damage, radiation, or oncogene, what happens? P53 activation occurs. Okay, P53 activation occurs. The P21 overexpression will be there. So basically, the P21 is a CDK inhibitor. If it is activated, more increased expression, it inhibits your cyclin CDK complex. Cyclin CDK complex is inhibited. RB remains, retinoblastoma gene remains hypophosphorylated. If it is hypophosphorylated, cell cycle arrest will occur at G1S phase. Okay. Cell cycle arrest will occur at G1S phase. So, whatever DNA repair, the cell cycle arrest occurs, DNA repair happens. Okay. Ideally, DNA repair should happen. Once the cell cycle is arrested, it gives time for DNA repair. If the DNA repair happens, the cell cycle continues. However, if the DNA repair does not happen, there is failure of DNA repair, the cell undergoes apoptosis. That is how naturally P53 helps in apoptosis of DNA repaired genes, DNA mismatched genes. Okay? If there is a failure of DNA repair, this P53 activation helps in controlling the division of that cell. That is how the cells undergo apoptosis. However, if DNA repair occurs, cell cycle will continue. Right? So this was the role of P53, guardian of genome. Now, we have another gene, RB gene, retinoblastoma gene, that is your gatekeeper of the cell cycle. Gatekeeper, again, the policeman or the gatekeeper of the cell cycle. Here also, the chromosome is 13q14. The gene involved is retinoblastoma 1. Again, two-hit hypothesis occurs at RB1 gene. And the transcription factor that is and this transcription factor inhibited by retinoblastoma is your E2F. Cyclin CDK complex that phosphorylates retinoblastoma is your cyclin B, CDK 4 and 6. Histological hallmark of retinoblastoma, we all know about this, is his Flexner Flexner-Winsteiner rosettes. Okay. If there is bilateral retinoblastoma, this suggests hereditary RB gene mutation. Please note the retinoblastoma gene is active when it is hypophosphorylated. When it is hypophosphorylated, and inactive when it is hyperphosphorylated. Okay, so you need to know the transcription factor inhibited is E2F, and the cyclin CDK complex that phosphorylates basically that activates retinoblastoma gene is your cyclin D CDK4/6. Okay, now what happens when the growth factor is absent? The retinoblastoma gene is active, it binds to E2A. There is no DNA synthesis. Retinoblastoma gene is active, it is hyperphosphorylated, it binds to ETF. There is no DNA synthesis, so there is cell cycle arrest at G1. On the other hand, if growth factor is present, cyclin D CDK4/6 is activated, it causes phosphorylation, E2F is released, DNA synthesis takes place, and your S phase of mitotic cycle begins. Okay, growth factor absent, retinoblastoma causes cell cycle arrest at G1, growth factor present, there is phosphorylation, E2F is released, DNA synthesis occurs, and the cell cycle continues. Okay, so this is how retinoblastoma gene activates. Very quickly, retinoblastoma gene is your gatekeeper of G1S checkpoint. TP53 is guardian of the genome. P53 basically controls DNA damage, helps in DNA repair, and this controls the cell cycle at G1S transition. This acts through ETF, the RB gene acts through ETF, whereas P53 acts through P21. Both of them act at the G1S checkpoint. Malignancy associated with retinoblastoma gene, we all know it is retinoblastoma, osteosarcoma, whereas more than 50% of human cancers have P53 gene mutation. Okay. Now, coming to the various other tumor markers, we all need to know because these can be asked as questions. CEA, usually seen in your colorectal, pancreatic, and gastric carcinoma. AFP, we all know hepatocellular carcinoma, yolk sac tumors, beta HCG, and choriocarcinoma, testicular tumors, basically the non-seminomatous germ cell tumor. LDH, usually seen in lymphomas and testicular carcinomas. PSA in prostate cancer, CA125 again in ovarian and epithelial, CA19.9 in pancreatic and biliary tract cancer, CA15.3, 27.29 in breast cancer, calcitonin, we all know medullary thyroid cancer, S100, melanoma, schwannoma, Langerhans cell histiocytosis, thyroglobulin in differentiated thyroid cancer, NSE, non-specific enolase, you see neuroendocrine tumors, small cell lung cancer, neuroblastoma, chromogranin, again various neuroendocrine tumors, carcinoid and pheochromocytoma, prolactin in prolactinoma, Bence-Jones protein vitiated, multiple myeloma, also we see beta-2 microglobulin in multiple myeloma, which is also seen in chronic lymphocytic lymphoma and other lymphomas. Okay, so this was all about the tumor markers and their associated malignancies. Now, coming to the Warburg effect. I did mention about the Warburg effect in my previous slide in the molecular basis of neoplasm. See, basically, Warburg effect is a paradoxical metabolic shift. Basically, paradoxical metabolic shift means there is aerobic glycolysis. Aerobic glycolysis even in the presence of oxygen. Aerobic glycolysis occurring even in the presence of oxygen. Although ATP is reduced ATP production is there, but the cancer cells, they have favored Basically, there is a favorable situation for the cancer cells where they rapidly divide. They have the nucleotides, amino acids, and lipids, which is required for their rapid division of the cancer cells, even though ATP is reduced, right? So, this helps survive the oxidative stress. ATP is reduced, NADPH is increased, oxidative stress is there, paradoxical metabolic shift, aerobic glycolysis, even in the presence of oxygen. This was your Warburg effect. So why do cancer cells prefer Warburg metabolism instead of normal oxidative phosphorylation? Why? Can anybody tell me? It reduces glucose utilization by neoplastic cell. No, glycolysis occurs. So it does not reduce, prevents apoptosis. No, it increases ATP production. No, in fact, there is reduced ATP production, but it produces metabolic intermediates essential for cell growth and survival. The one which we saw earlier, nucleotides, amino acids, and lipids. These intermediates are necessary for cancer cell growth and proliferation. So this is the correct answer. Now, coming to amyloidosis, again, very important from your exam point of view, although a very simple topic, but very important, very significant topic. What is amyloidosis? Amyloidosis is a group of protein misfolding disorders characterized by extracellular deposition of fibrillar insoluble proteinaceous substance called amyloid. Okay, we have 95%, it is fibrillar beta-coated fiber, beta cross-plated fibers, and we have non-fibrillar less than 5%. In the fibrillar protein, where there is AL fibrillar protein or AA fibrillar protein. AL is composed of your immunoglobulin light chains. You usually see lambda more than kappa light chains, and AA fibrillar protein is because of serum associated protein, that is your acute phase reactive. Okay. Systemic amyloidosis, we all know primary amyloidosis can be divided into systemic and generalized, primary and secondary. In systemic amyloidosis, the associated disorder is your plasma cell dyscrasia. And what type of fibrillar protein you find here? You find AL type. Okay. Secondary, usually seen in chronic infection and inflammation. What is the type of protein that you see? AA here. Hemodialysis, chronic failure, renal associated with chronic renal failure, and you see A beta 2M. Heredofamilial, you see A TTR, right? In senile cardiac amyloidosis, what do you see? Again, you see ATTR. Senile cerebral associated with Alzheimer's disease or prion disease, what kind of protein do you see? Fibrillar protein, A beta or APRP. Medullary thyroid cancer or diabetes, what do you see? You see either procalcitonin or proinsulin. Tumor forming, again you see AL fibrillar protein. All right. So this was about the amyloidosis, systemic and generalized. Now dividing into primary and secondary. Primary, the composition, we all know it is AL, AA, and you see plasma cell dysplasia, B-cell lymphomas. Here you see chronic inflammation, Hodgkin disease, other autoimmune disease. What is the pathogenesis in primary amyloidosis? There is monoclonal B-cell proliferation leading to excess of immunoglobulins and light chains. The partial degradation of these light chains result in your insoluble AL fibrils. Okay, the insoluble AL fibrils is because of degradation of your excess of immunoglobulins and light chains. On the other hand, secondary amyloidosis, because of chronic inflammation, there is activation of macrophages, cytokines are released, there's partial degradation and acute inflammation, partial degradation leading to insoluble AA fibril. Okay, insoluble AA fibril. Prognosis is better in your primary. Prognosis is better in your secondary amyloidosis. Primary amyloidosis, it is progressive. Stains, very important. What are the stains we use? Congo red stain, whether it is primary, secondary, AL, AA, or any form, Congo red stain, and the specific immunostain, you can see the kappa or lambda antibodies. Okay, how do we see that? Sorry, what are the staining characteristics? Already discussed. How do you see a myeloid in histopathology and H&E? You see pink, hyaline, homogeneous deposit. Methyl violet or crystal violet stain, you see metachromasia. That is a rose pink appearance. Then the confirmatory stain is your Congo red. On light microscopy, you see it as pink red, and you see apple red green birefringence under the polarized light microscope. Then thioflavin T and S, you see it under ultraviolet, you see the fluorescence, or you can see the specific immunoreactivity against your kappa or lambda light chains. All right. Now, this is your histopathology. You see pink amorphous material here, Congo red, bright red, and this is under apple green birefringence in polarizing microscopy. Okay. Now, what do you see it in kidney? Kidney, basically the kidney cell, the kidney is enlarged. Basically, your kidney is enlarged, waxy, pale. You see deposits in, initially you see deposits in the glomerular basement membrane. Even you see deposit in the mesangium. And later on, the resulting symptom is nephrotic syndrome. Okay? Nephrotic syndrome. Spleen, what do you see in spleen? You see sago-spleen. Sago-spleen, what area is affected? The white pulp. Glaudaceous spleen, what area is affected? The sinuses, splenic sinuses, and the red pulp. Okay. What do you see it in heart? You see restrictive cardiomyopathy. Histology, you see speckled or granular appearance. Okay, speckled or granular appearance. GIT में the most common feature you see in GIT is macroglossia. Okay, large tongue. So classical triad of your AL amyloidosis is macroglossia, nephrotic syndrome, and periorbital purpura, also known as panda's eyes. This is your AL amyloidosis ka classical triad. Okay. Coming to next question. There's a 53-year-old woman presenting with complaints of fatigue, nausea, generalized swelling, proteinuria. There is anemia, neutropenia, bone marrow, 22% plasma cell, acellular eosinophilic deposit. See, again, the stem of the question is very long. We know it is a case of, most probably it's a case of multiple myeloma or any plasma cell dyscrasia where you see increased number of plasma cells. So plasma cells ke andar, what do you see? You see primary amyloidosis. Primary amyloidosis. So, and here also the image you see, bone marrow biopsy is given. What do you see? You see pink amorphous material. So the most likely associated pathology is your amyloidosis. It is not necrosis. It is not myxomatous degeneration or coagulative necrosis. It is amyloidosis. Okay, now very quickly studying about the 4 types of hypersensitivity that we know about, type 1, 2, 3, and 4. Type 1 is anaphylactic, type 2 is cytotoxic, type 3 you see serum sickness, Arthur's reaction, and this is delayed type of hypersensitivity or type 4. Okay, the main factors involved IgE antibodies in type 1. Others you see IgG and IgM in 2 and 3. However, in type 4, you see no immunoglobulins. The role is of, it is mediated by T lymphocytes. Pathogenesis, type 1, there is formation of immunoglobulin E antibodies, mast cell degranulation, and release of inflammatory mediators. However, in type 2, there is opsonization and phagocytosis, antibody-dependent cellular cytotoxicity or antibody-mediated cellular dysfunction. In type 3, there is circulating immune-mediated tissue injury. There is immune complex injury. Type 4 is because of T-cell mediated, CD4 mediated, CD4 plus T-cell or CD8 plus T-cell mediated cytotoxicity. You need to learn about the examples of type 1, 2, and 3, 4. Type 1 में you have anaphylaxis, hay fever, asthma, allergy, urticaria, angioedema. Type 2 में autoimmune hemolytic anemia, transfusion reaction, ITP, leukopenia, Graves' disease, Goodpasture syndrome. All of these are examples of type 2. Type 3, SLE, very important, immune complex glomerulonephritis, rheumatoid arthritis, polyarteritis nodosa is an example of type 3. Serum sickness, drug-induced vasculitis, arthritis reaction, reactive arthritis. Tuberculosis, we all know it's a type of type 4. Then transplant reaction, rheumatoid arthritis again, multiple sclerosis, inflammatory bowel disease. You need to learn the examples and the mediators of all the types of hypersensitivity. Okay, now coming to SLE, very important. It's a chronic multi-system autoimmune disorder characterized by the production of autoantibodies against the nuclear antigens. These are your ANA, leading to immune complex type 3 hypersensitivity mediated tissue injury. What happens there? Your genetics and environmental factors together combined, there is loss of self-tolerance, autoantibody formation, leads into complement activation and inflammation and tissue damage. Very brief, please go to your comprehensive lectures to study what are the genetic and environmental factors and how does autoantibody formation lead to complement activation leading to tissue injury. So very important, what are the antibodies that we see in SLE? First of all, anti-nuclear antibody, this is the most sensitive for SLE. Okay, most sensitive, around 95% sensitive for SLE. Anti-DS DNA, double-stranded DNA, this is the most specific for basically lupus nephritis and monitoring the disease activity. Anti-SM, anti-Smith body, again, highly specific for SLE. Antihistone is usually for drug-induced lupus. Anti-Rho SSA is for neonatal lupus. Sjogren's syndrome. Anti-La SSP again for neonatal and lupus and Sjogren's syndrome. Then APL, what does it signify? Thrombosis, recurrent abortions, increased APTT. Okay, increased APTT. So these were the antibodies for SLE. What do you need to know about lupus nephritis? Please learn the WHO ISN classification. You need to learn about the wire loop lesions. Okay, wire loop lesions. These are the subendothelial deposits. Also, you need to learn about the full house seen on immunofluorescence. What do you mean by full house? You see all the immunoglobulins there. The immunoglobulin G, A, M, in fact C3, C1Q, all you see it in your full house immunofluorescence. Skin me, what features do you see in skin? You see a malar or a butterfly rash. Okay, you see discoid lesion or basal cell degeneration. Heart में the characteristic feature of SLE is basically Leibniz sac endocarditis. You see vegetation on both sides of the valve. Also, you see pericarditis. right? Blood में what do you see? You see autoimmune hemolytic anemia, leukopenia. So these are the clinical features that you should know about SLE. Okay, then immunofluorescence pattern. There are 4 types of immunofluorescence pattern. The homogeneous or the diffuse nuclear pattern, nucleolar, speckled, and fourth we have peripheral. This has also been asked as a question. You need to know about the homogeneous diffuse. You see the pattern, the entire cell, nucleolar, this pattern. Then speckled, you see speckled pattern. And peripheral, you will see it in the periphery of the cell. Okay. So these are the immunofluorescence pattern. Now, coming to primary immunodeficiency. Primary immunodeficiency, the type of defects we see it in the B cell defect, T cell defect, combined B and T cell defect, phagocytic defects, and complement defects. These are the examples that I have mentioned. B cell may you see X-linked A gamma globulinemia, selective immunoglobulin A deficiency, common variable immunodeficiency, T cell defect, Digeorge syndrome, combined B and T cell is seen in combined B and T cell, seen in severe combined immunodeficiency, Viscott Aldrich, ataxia telangiectasia. Phagocytic defect, you see chronic granulomatous disease, leukocyte addition defect, Shediac-Higashi syndrome, complement again the particular deficiencies, complement deficiencies you can see. Okay, very simple. 2 questions, 25, 24. These now they are, I mean, general अब कुछ रहता नहीं है, so they are targeting more of primary immunodeficiency disorders. Usually questions are asked about severe combined immunodeficiency. Straightforward clinical history they will give you. Recurrent, a young 8-month-old infant, recurrent infections, failure to thrive, low B and T cell count. That means both B and T cell defect. ADA deficiency, so which immunodeficiency describes the best? See, both B and T cell is in severe combined. Okay, Digeorge is only T cell. Alpha-1 antitrypsin is not a primary immunodeficiency. Hypogammaglobulinemia involves the B cells only. Okay, now coming to a child presents with failure to thrive and recurrent infection. Again, the same history. Examination reveals absent tonsils here. Further evaluation confirms ADA deficiency. What is the most likely diagnosis? Again, here it is severe combined immunodeficiency. Absent tonsils, recurrent infection. Recurrent infection, T cell defect. Absent tonsil, B cell defect. So it is both both B and T cell defect. So it is severe combined immunodeficiencies. Understood? Read the question properly, read the history. Okay. Now coming to the various deficiencies in particular, X-linked A gamma globulinemia is Bruton's disease. You have BTK gene mutation. There is absent mature B cell. Because there is absent mature B cell, all the immunoglobulins will be reduced. Recurrent infections, small or absent tonsils, and lymph node. Here, selective IgA deficiency. Please note that this is the most common primary immunodeficiency. Isolated IgA deficiency, and an important feature to remember in this, there is risk of anaphylaxis after blood transfusion in selective IgA deficiency, right? Digeorge syndrome, remember catch-22. Catch-22. Failure of third and fourth pharyngeal pouch defect. Catch-22, cardiac defect, abnormal faces, thymic hypoplasia, cleft palate, hypocalcemia, and 22q11 deletion. Okay. Severe combined immunodeficiencies, again, both B and T cell deficiency, ADA deficiency is there, both B cell and T cell immune deficiency. Common causes usually IL-2 receptor gamma chain mutation. It is X-linked. Recurrent infections, failure to thrive, chronic diarrhea, absent thymic shadow on the chest X-ray. Viscott-Aldrich syndrome, triad of Viscott-Aldrich syndrome is weeping eczema, absent platelets, severe infection. Okay. Weeping eczema, that is your pustules, absent platelets, severe infection, immunoglobulin M is decreased. Then chronic granulomatous disease, there is NADPH oxidase deficiency, catalase positive. These patients are susceptible to catalase positive organism, and there is abnormal DHR test or negative NBT test. I'm going very fast on these deficiencies. You just need to learn what are the very important features of these. Okay. Now, leukocyte addition defect, there is C18 integrant deficiency. There is delayed separation of umbilical cord in this. Okay, the most important feature to remember here is delayed separation of umbilical cord. Recurrent infections, no pus, and there is neutrophilia. Shediac Higashi syndrome, there is LIS gene mutation, recurrent pyogenic infection, partial albinism, peripheral neuropathy. We will see giant granules and neutrophils. We will study just Shediac Higashi again once we are studying platelets. Okay. Okay. Now, these were your primary immunodeficiency. Now, the recent updates that can be asked in this NEET PG, liquid biopsy is again coming up. What is liquid biopsy? It's basically a non-invasive diagnostic test that detects tumor-derived materials in the body fluid. Body fluid. So here you use body fluid as a sample rather than a tissue sample. Okay, rather than a tissue biopsy, you use body fluid. So it's basically a non-invasive, and the most common body fluid used is blood. Non-invasive, you detect the circulating tumor DNA here. Okay, you detect the circulating tumor DNA, which is useful for your molecular profiling, treatment monitoring, detection of minimal residual disease, and also detecting for recurrence. You can use it most commonly. It is used in EGFR mutation testing in your non-small cell lung cancer, where the tissue is not sufficiently available. Basically, liquid biopsy complements but cannot replace the tissue biopsy for initial diagnosis. You can use it for treatment monitoring, molecular profiling, but for initial diagnosis, tissue biopsy is the best sample. And moreover, liquid biopsy, you do not see the morphology of the cancer. Morphology can be seen only on tissue biopsy. Okay. Now, AI in pathology, AI is being used everywhere. Can we use AI in pathology also? Yes. Digital pathology is the foundation of AI pathology. We use whole slide imaging. See, microscopically, there is only a field where you can analyze or visualize the slide. But whole slide imaging can be used in digital pathology. Deep learning, or the CNNs, is the main technology that is used in histopathology. It is basically used for tumor detection, grading, and IHC quantification. Okay, where you need to analyze the entire slide for tumor detection, the grading of the tumor, for the IHC quantification. And please note, AI is just an assistive tool. It can only assist you. It cannot replace a pathologist. Okay, what do you do here? You take a glass slide, whole slide image analysis is done through an AI. After that, a pathologist is required for verification and in the final diagnosis, right? So whole slide image can be used by AI algorithms, but then a pathologist verification is necessary to make the diagnosis, right? So with this, we end this session. I'll give you a small homework for tomorrow. We just studied about the primary immunodeficiencies, and these are the features that we see in specific primary immunodeficiency. I need you all to list down the various features and the corresponding disorder. This we will continue tomorrow. We'll start with the hematology section. All right. Thank you so much. For more updates, you can scan the Diginerv page, and we do have a limited time offered for you all. Thank you. I hope you had a useful session. We will see tomorrow. Please do the small homework, and we will continue with the hematology section tomorrow. That's all for now. Thank you. Have a nice day. Although the day is over, great. Bye-bye.